Hello and welcome to Masterclass 4 Zero Fluoro Robotic Ablation, which is organized by Stereotaxis and the Society for Cardiac Robotic Navigation. Diagnostic radiation, which includes fluoroscopy, is an effective tool that can save lives. However, the higher the doses of radiation delivered at any one time, the greater the risk for long-term damage. If patients receive repeated doses, harm can also occur at the cumulative effect of those multiple doses over time. Zero fluoroscopy procedures reduce radiation doses both instant and over time for both patient and physicians. With the assistance of robotic CP, zero fluoroscopy is a valid and safe option to treat patients. Today, we are hosting a pre-recorded procedure for Dr. Pedram Kazemian from the Deborah Heart and Lung Center, and we will listen to the broad experience Dr. Robert Percell from the Bryan Medical Health Center has to share on this very interesting topic. Together with our esteemed faculty, we have prepared an exciting agenda. The Masterclass series is a very successful series, including Masterclass 1, the supreme efficiency with robotic EP, 6 AF patients in an 8-hour workday, Masterclass 2, Stereotaxis Genesis, a new era begins, and Masterclass 3, Cool and Collected, Pulmonary Artery Denervation. In case you have missed one of these, please have a look at the Stereotaxis and SCRN YouTube channels. Follow us there to also get access to the recording of this Masterclass 4 Zero Fluoro Robotic Ablation. Please note that making recordings or screen captures during this event is not permitted. Also, we kindly inform you that our operators and moderators may discuss or present information on Stereotaxis products. They may make product claims or use techniques that may not have approval or clearance in all regions of the world. Kindly note that presentations or discussions may feature products that are not manufactured or distributed by Stereotaxis. Prior to using devices, please always review the instruction for use for complete listings of indications, contraindications, warnings, precautions, and potential adverse events. At present, I'm very happy to introduce to you our moderator, Dr. Tamas Szili-Torok, who will in turn introduce to you the rest of the faculty and the program. Dr. Tamas Szili-Torok is a cardiologist, electrophysiologist, the clinical head of cardiology and electrophysiology of the Erasmus Medical Center in Rotterdam, the Netherlands, and he is also one of the founders of Society of Cardiac Robotic Navigation in Europe and a board member of the SCRN Global Organization, in charge of organizing high-quality educational events such as the Masterclass series. Dr. Tamas Szili-Torok, the stage is yours.
Marus, thank you very much for this excellent introduction. First of all, good morning, everybody in the States, and good afternoon for the European participants, the ones who are actually watching this event, despite the fact that the Hungarian team is playing against the French team at the moment at the European Football of Soccer Championship. Being a Hungarian, you see, it's all about priorities. I'm here with you guys, and we will discuss a very important issue today. And but before that, let me to start with a broader introduction and to explain to you why we started these master classes. So when I started to use the Stereotaxis system almost 15 years ago, I realized that there are some common perceptions, and I must say also some common misperceptions related to this system. Obviously, at that time, we had the disadvantages, and together with Stereotaxis, we initiated quite a few projects to improve the outcome of patients and the lab efficiency in many types of procedures. But on the other hand, from the very beginning, we also realized that there are misperceptions which are probably related to some inappropriate knowledge of the users or the non-users. So when we designed these master classes, we aimed two very important things. The first one is just to tackle these misperceptions, for instance, inferior efficiency. And I think we performed that in Erasmus Medical Center. We proved that if you can treat 6 pulmonary vein isolation patients within 8 hours, that should be efficient. So that this discussion should not take place anymore, at least not in the magnitude that was in the past. The other most important issue why we started these masterclasses was to introduce unique procedures and unique perspectives for the ones who are already using Stereotaxis system or who are designing to use Stereotaxis system. So again, all of these masterclasses, although are arranged by the Society of Cardiac Robotic Navigation, these are all performed together with the Stereotaxis, and we focus only on the Stereotaxis system in these masterclasses. Which were those unique features? One of them is the new hardware which was introduced. So in a second masterclass, we showed to you guys how the Genesis new system, the new hardware works. And the third one was a very unique type of procedure, treating patients with pulmonary hypertension. It was, I think, also a great success. Now, from the very beginning of electrophysiology, we are dealing with relatively long fluoroscopy times. And it's very, I think, obvious that robotics, such as, should have a crucial role of diminishing fluoroscopy times in the EPLM. Having said this, I would like to give the word now to the other moderator who has also pioneering work in the field of electrophysiology and especially in the robotics, and also a lot of work regarding fluoro reduction. So I would like to introduce Sabine Ernst and asking her to make an topic-specific introduction today.
Thank you, Tamas. Yeah, I think in a way, magnetic navigation and zero fluoro seems to be kind of a logical fit. And that, I think in my personal practice, that was actually a system that in both ways I learned a lot to avoid radiation. And we started with a system long time ago, 18 years ago, to use robotic navigation. And the nice thing was always that we had so much image integration features available on the system. Right? The philosophy of an open platform where you could look into integrating 3D imaging relatively early on, a picture-of-picture display where the maps aligned in your reference screens that you could take on fluoro. And overall, I think the position of the physician being so close to the signals, being there, not concentrating on holding a catheter in place, but looking at the signal, see how it changed if you did small movements to really micro-navigate, if you want, so to the final ablation site, for example. I think that all highlighted the key features for EP, let's say, it takes a bit away the big picture, but helps you homing on on the true target. And maybe also because the catheter is so stable and it's soft and it swings with the tissue, you need to be fairly precise. So target identification was a key feature, especially in the early years where we didn't have an irrigated tip catheter, for example. So that's something that we have learned by doing it, that it's not as forgiving as the manual catheter that slides a little bit over the tissue, basically allows you to make a slightly larger lesion. And I always said it's like a precise, say, an expert set of skis. You need to know how to ride on an expert set of skis. Otherwise, you're going to have a crash with your procedure. So, of course, with the operator sitting in the control room, that's a kind of a fair statement that the radio protection for operators was always clearly the case with magnetic navigation. But of course, at some point, we realized that we didn't even use as much X-ray because we felt so confident where we were. I think here again, I'm sure we're going to hear that from in the presentations today, that the sheer fact that you don't have to question where the catheter is. It's the sheer knowing where it is that you don't X-ray anymore. And you follow the the catheter around, and you're very happy, at least I'm very happy, to move in a virtual kind of 3D world. Now, I think it's an important topic. Radiation protection is a key feature for us professionally. I might be extra sensitive to this topic as one of the female operators in EP, but I think everyone should. And we have all heard about radiation, let's say, professional radiation exposure and our risk as professionals doing this job for many years, many decades, and running a risk for having a higher cancer risk, for example, having problems with orthopedic injuries. Yeah, I had a skiing accident that motivated me to start with Stereotaxis. So there are lots of good reasons, and I tried to say that we should have not only the reason of protecting our patients, but we should be egoistic and protect ourselves. Now, I think this is maybe a good enough introduction of why I think this is such a natural coming together of two things that just, by the sheer definition, belong together. Let me introduce the first speaker, which is Dr. Actually, let me say, first of all, that there are two speakers. The second one is Robert Percell, and Tamas is going to introduce him in a bit. The first speaker, however, is Dr. Pedram Kazemian. And Pedram has been trained and educated initially in Canada. I understand his medical degree and the medicine residency was in Toronto. Then he moved, of course, to the best place to learn EP, or the best city to learn EP, which is Boston, in my opinion, at least. He was at Brigham and Women's for part of his EP fellowship, and then went to the St. Elizabeth Medical Center, which belongs to Tufts. And there's a little personal connection here. I was at Tufts many, many, many years ago. I'm not even saying when exactly for an internship, but I have a good collection from the New England Medical Center. I've actually never been at St. Elizabeth. So it's just that I was at Tufts for about, 4 months or something. But I have a very good reflection on that. He's now practicing at the Bethesda Heart and Lung Center in Brown Mills in New Jersey. And he's a member of the SCRN Global Board. And yeah, he has been one of the advocates of zero fluoro and of course magnetic navigation. And I'm very, very keen to hear all the tricks that he can share with us, how to make it truly zero fluoro and how he uses the robotic system. So Pedram, please share your knowledge.
Thank you very much, Sabine and Tamas, for a very kind introduction. I do agree with everything that was said. Obviously, if you review all the literature regarding robotic navigation, invariably you'll find that one of the strengths is reduction in fluoroscopy, and that's been proven over and over again. But now we live in a different era where you can completely eliminate fluoroscopy, and this has been done with the manual catheter. And I think this talk is timely in a sense that we can show that the same can be done, in fact, even better with the robotic navigation. So without any further ado, I'm going to start my talk. For technical reasons, we're not able to do live cases, but I think this is actually for the better because we can pick up the areas that are more interesting and relevant. And I prepared some videos of 3 cases, essentially, which we're going to discuss. The first case is a PVI in a patient with paroxysmal atrial fibrillation. The second case is an ischemic Vt, which is done without fluoroscopy. And the third case is the right atrial SVT. And the reason I picked these 3 cases is that I want to show that the versatility of fluoroless ablation, where you can apply to any chamber of the heart, short of epicardial ablation, any of the ablation can be done without fluoroscopy. So just one basic introduction about how these cases are done. Really, there are 5 general steps that we have to go through. The first step, which is specific to Stereotaxis, is how to set it up without using fluoroscopy, which is pretty straightforward. And I think that issue is resolved now with the new system. Gaining access, vascular access, navigating the catheters towards the heart without the use of fluoroscopy, and then how to use electro-atomic mapping and ICE to move the catheter and do transseptal puncture. And lastly, mapping the chamber of interest and ablation. So I will go through all these 5 steps for the first case, and for the second and third, I will skip the ones that were similar, so to conserve some time for discussion later on. With regards to stereotaxis, the older systems, as you know, you need to have a fluoroscopy image of the patient to be able to so-called merge the fluoroscopy with the electro-atomic map and the dots that you have to find. Now, since we're not using fluoroscopy, there is no need for merging the images. And any stock images, which we use one, which you can see in the top left corner of a table, essentially, there's no patient there. And we use that essentially to trick the system to register the data. I mean, we don't need the registration, but this would allow you to start your case without registration. And in my case, I do my ablation and mapping in the same system. So with the Carter system, for example, you can navigate the stereotaxis, you can map, you can do electro-atomic mapping, you can clear your map. So it makes it very convenient to see your map, to see your signal, to do the pacing, everything in one system, essentially. Now, let's start with the case number 1, which is a 66-year-old female. Had a 2-year history of atrial fibrillation, which was initially paroxysmal in nature, was started on Sotalol. Nonetheless, the patient progressed and had more frequent episodes, eventually converted to the persistent form. Had a Chas vascular of 3 and was on Eliquis. Had a history of 6 sinus syndrome and had received a dual chamber pacemaker. And intentionally, I picked the cases that had pacemaker in there because one of the concern of using fluoroless or zero fluoroscopy is it safe to use it with pacemaker? So 2 of these cases have pacemakers. The first part is access. So to me, the access is very important because the most common cause of complication with the EP procedure is groin complication. And now, generally speaking, what we do is that we look at the ultrasound and we can see femoral artery and femoral vein. But what we don't have when you don't use fluoroscopy is the landmarks to guide you to the level where you have to get the puncture. As everybody knows, obviously, during the fluoroscopy, we aim for the head of the femur as a landmark to puncture so that we be above the bifurcation and avoid the pseudoaneurysm or fistula between the artery and vein. So we don't have that with zero fluoroscopy. Is there a way to, are there any other landmarks that we can use? Yes. So what we do is that we can rotate the head of the ultrasound and look longitudinally, look at the artery, and look at the bifurcation side of the common femoral artery and femoral vein. And this requires moving the probe 90 degrees several times back and forth to find the appropriate level where it puts the puncture site just above the bifurcation. And this corresponds to the head of femur when we're using fluoroscopy. So this was, as you saw the bifurcation, we moved the probe upward towards the patient's head. And now you will see the micropuncture accessing and puncturing the femoral vein right about there. So just a front puncture, single puncture site. And then after that's done, you can confirm that the wires actually are in appropriate location. So you rotate the probe 90 degrees, you find the bifurcation, and you move it cranially, and you see the wires are entering the vein cranial to that. So that's very important. I know it's sometimes considered pedantic, but it really does reduce complication rates. The second aspect is that once we get access, we'll have to move the catheters towards the heart. So again, one of the concerns is that how would you move a ICE catheter, which is relatively stiff, and not worry about perforating the vasculature? You're not seeing it on the fluoroscopy. The answer is very simple. I mean, you don't see vasculature on the fluoroscopy. So when you have ice, you can actually see the vasculature. And what you have to do is this posterior wall of the vein. So you always have to see a black triangle at the top of your image saying that you are within the vein. As you go up, you will see other structures. For example, this is bladder, you will see in the pelvic area. As you go into the iliac, common iliac, you see the branches of iliac. So this is external iliac. It tells you that you will very soon reach inferior vena cava, which on the right side has a relatively narrow angle, but in the left side, this angle could be pretty steep. So I generally recommend approach using the right axis for the ice. As you go up the IVC, you will see liver and you enter the heart. This patient has a lead, as you can see the RV lead. So one of the first thing I do, I go to the right ventricle and take a look at the LV to rule out effusion. It's extremely important to make sure before the start of the case that the patient doesn't have chronic effusion. You will be forced to look at this during the case sometimes, and you will be misled if you have not looked at the beginning of the case. And literally this takes 5 seconds. So afterwards, we'll come slowly out of the right ventricle back to the RA. And right at the base of it, you will see the ostium of the coronary sinus. You can mark that if you have a special echo probe, which is right about this point. So that's the os of the coronary sinus, and you see mitral annulus far out. And left atrial appendage on the farthest side of it. This is a very good image of it, although I wouldn't rely on this one to rule out left atrial appendage clot. If you want to do that, you have to put other views, which I'm not going to discuss today. The most important view for atrial fibrillation is this view of the right atrium, where you tilt the catheter posteriorly and to the left, and this gives you a very nice view of the SVC. As you can see, this patient has leads coming down there, and we visualize the movement of the catheter into the SVC. So on the right, you see the Carter image. In a second, you see penta-array, which I use for mapping the right atrium coming up. You can see it here in the SVC appearing there. And as I go up into the SVC, under complete visualization, you will see the penta-array moving in and out of SVC corresponding to the movement of the penta-array in the Carter. So we'll start with mapping the SVC. And then once you have SVC and IVC, the rest is very easy. So the right atrium, and I sped up the images, the video, so that doesn't take too much time. We create a rudimentary anatomy of the right atrium, which I'm going to show in this image also. So this is essentially the same one that I showed you without the ice images. You're looking at the signal, and it tells you which chamber you're in. Obviously, the signal disappears in IVC and SVC. And when it gets into the right atrium, you see full signals of the right atrium. I always try to get a His signal, even if you're not doing SVT ablation. That gives you some confirmation about the chamber you're in. And then ostium of the CS is very easy to map with the penta-array. You may not be able to go into the coronary sinus completely with it, and that's fine. You don't need that. So as long as you have a little bit of the ostium, that should suffice. So this kind of a rudimentary right atrial map, which takes about a minute or two, will substitute your fluoroscopy image that you would need for transeptal and catheter placement later on. Now, a quick point about the view for transeptal with ice. So these are 3 cuts of the CT cuts of the heart going from front to back. The frontal cut, if you look at it, you will have a very good image of SVC. With that, you will see part of the aorta and aortic valve. But as you can see, there is not much of the left atrium here, and you don't see a good view of the left atrial appendage. Sorry, left interatrial septum. As you go back, you see that the left atrium will start to appear here, still predominantly showing the SVC, and the aorta gradually disappears. At the level where you probably want to go transseptal, where you see pulmonary veins, there is no view of the SVC, and usually not much of the aorta is seen. So that is sort of confirmation, and this is another way of looking at it essentially. So this is the front where you have the aorta. This is the mid portion where you start seeing some of the left atrium, and this is the posterior where you see all the left atrium but no aorta. It sort of highlights the fact that during the procedure for transseptal, you have to adjust the direction of the ICE catheter, starting with the anterior view. So we can localize the SVC, and once we tented the intraatrial septum, then we relieve some of those forward sideways bends, and maybe clockwise to look posterior to be able to find the right view for transseptal access. So I'm going to highlight that with this case. So again, going back to the original view where we saw the SVC, you see mitral valve here and a little bit of an appendage in a second. This is the atrial lead. We put the J wire of the long sheet. I use the Gillis, so this is the wire for the Gillis. You can see it went up to the SVC. And in a second, we push the sheet over the wire, and that's the beginning of the sheet coming up. So as the sheet goes up, you rotate the catheter. This is the sheet. You can see it sitting in the SVC. And we'll take the wire out and flush the sheet. Of note, I will give 10,000 heparin right off the bat as we get the short sheet in the groin, because a lot of time clot is formed on the wires, and you certainly don't want to take them to the left atrium. Now, the concern everybody has is that how would you pull this sheet down without affecting this lead? The fact is that you actually see it. So you see the sheet is coming down and it's interacting with this right atrial lead. You will not pull the sheet down because you will tangle with this. You have to untangle it while it's in the SVC. And the way you do it is just a slight clockwise rotation, and the counterclock, you see, it was released from the atrial lead. So now we can gently pull it down, and it will tent the intraatrial septum. But this is not the best view. As you can see, most of the aorta. So this is the very anterior. So you have to relieve some of that backward deflection. And now we have a better view of the intraatrial septum. And in a moment, you'll see the pulmonary veins show up on the far side, which is right about there. So left superior and left inferior pulmonary veins. And this is the view that you want to see. So you can go transseptally right at the level that is useful for the procedure. We use safe set wires, which is now going through, as you can see it right here. And we push the safe set all the way going to left superior pulmonary vein. So you don't need fluoroscopy. You can see it with the echo. Once the wire is in the vein, you push the sheet with the needle's out, the dilator is out, so sheet is completely transseptal in the left atrium. And you have safe distance to the lateral wall. There is no way that it would cause any perforation. This was done over the wire with complete visualization. Then we put the pentarray catheter in, and we continue using ICE for directing us toward where we want to go. So if you want to put it in the left superior pulmonary vein, we can look at it under fluoroscopy. You can see it goes up into the left superior, and then in a second we'll pull it back, and you can bend the deflect downwards the sheet like that and direct it towards the left lower pulmonary vein. So you use ICE throughout the procedure. It's not just for transseptal. I will obviously show you the rest of the case and how the ICE is used. You can look at the, so this is in the right lower right now, sorry, left lower, and then now it's flexing backwards to go towards the right side in a second, right there. And you can see the sheet will bend upward, and that's where the right upper pulmonary vein is, right about there. So we confirm the location of the catheters and sheath throughout the procedure. Now you start seeing some of the mitral annulus and the appendage showing up here. So if you don't want to go to appendage, which I never intentionally go to unless there is an appendage AT or something that I want to map, you can avoid it by just focusing your ICE catheter toward the appendage. So once that's done, we put the coronary sinus catheter in. Now these decapolar catheters are not navigation catheters, but once you create a geometry on the right atrium, you would be able to see it. Now, sometimes they disappear when they go into the CS because we don't have a matrix formed there. And that's fine because you can look at the signal and that will tell you that you're in the coronary sinus. So that's pretty much the initial part of the study where we had the access, we navigated sheaths and catheters to the right atrium, we did the transeptal, and now we're gonna do the mapping of the left atrium. So I sped up this part because I'm sure you're not interested looking at the left atrial geometry creation, but this patient had a CT scan, although it's not necessary. And in many patients, I skipped the CT scan. But just to show you, again, this is a sped up video, but I'm using a pentarray to create a left atrial geometry and voltage. Now, the other issue is the esophageal temperature probe. So I know some people don't use the probe. The evidence for it is obviously lacking. It's very difficult to prove that it's beneficial. I do use it in my practice. And in order to be able to visualize the location of the esophageal probe, there are two ways. Previously, I used to put a quad diagnostic catheter and just tie it to the probe. And when we hook it up to the system, it will localize the quad location, the tip of the quad catheter, which correspond to the tip of the esophagus, and you can see it on the map. Nowadays, I don't do this. This actually goes very nicely inside the probe. So this way you don't even have to tie anything on the outside and keeps it very smooth. You have to create a small hole in the plastic coverage because these are impedance-based mapping catheters and they need to have contact with the tissue. But once you do that, then you can see it on the map. So this catheter here is essentially quad catheter attached to the esophagus, and we can see exactly where located. We can actually continue looking at it during the procedure if it moves up or down, or we can actually intentionally move it up and down. The magnets now come out, ablation catheter is in place. And what I do for ablation is that I pace and ablate at the same time. And there are three benefits in doing this. So as you can see, is pacing, is capturing the left atrial, and then I'll come on ablation. The first benefit is obviously proves that you have contact with the tissue. If you're floating in the left atrium, you won't be able to capture. The second is that as you achieve transmurality and ablation, you lose capture. So that's a kind of a hard outcome of adequacy of ablation side. The other is that pacing at 100 beats per minute at the side, it kind of stabilizes the catheter. Once we lose capture, we move, I burn for about 10 more seconds and then move to the second point, and we start again the same thing. We start pacing and we start ablating. I use 50 watts and I watch the temperature. Obviously, if temperature goes up, we'll move the catheter somewhere else. But 50 watts seems to do the trick for the RMT catheters without any problems. If you decided not to pace from the ablation catheter, I would still suggest maybe pacing from coronary sinus. It definitely increases the stability of the catheter and reduces some of the cardiac motion. Now, sometimes you may not lose capture because we're pacing at the high output of 20 milliamp or 10 milliamps, and you're capturing adjacent tissue. In those cases, when you ablate just above and below and you come back to that point, you will lose capture. Nonetheless, at every single point, I have to confirm that the capture is lost. Now, here we're very close to the esophagus. The temperature went up, so I immediately moved the catheter, went anteriorly away from that, continue ablating anteriorly and let the esophagus cool down a bit. The other thing that you notice is because I'm actually sitting behind the cardo, I'm adjusting the map as we go. So I delete and fill the map, because with the Pentaray, one of the downside is that I know Tamas is very keen on actually creating a map with the ablation catheter because it's more accurate. What I'll do is that I delete and generate the anatomy as I'm ablating. So this way I save some time and then create a very accurate map. So we'll back again to the posterior where the temperature went up, deflected anteriorly. In terms of the position of the sheath, I try to pull the sheath back all the way to the septum for most of the cases, unless there is an area where there is difficulty reaching this, which I'm going to show in a second. Now we'll go on to the right side. We're ablating. As you can see, there is some difficulty in having adequate contact in the middle, but that's fine. I'm going to leave that area. I'll come back to that in a few seconds. So what we can do is that in those cases, we can deflect the sheath and create this sort of U-shaped form in the left atrium. And this will direct the tip of the ablation catheter directly towards the right veins. And doing this, we will have no problem achieving contact for any point on the right side. And I believe with the new catheter, the magnets, the number of magnets have increased, so that will give us more power in terms of control over the direction of the catheter. So once the veins are isolated, we pace inside the vein with the ablation catheter, make sure there is an exit block, and then I switch to the Pentaray, again confirming both exit and entrance block. I apologize for the map. The map on the right is actually left LAT, but the one on the left side is the bipolar voltage. And as you can see, that vein is completely isolated. And we're pacing through. And the left side is ablated as well. So this is actually at 0.01 millivolts. So that's why it looks not as dark red, but trust me, all four veins are completely isolated. So this is sort of my workflow for fluoroless AFib ablation, and 100% of my cases are fluoroless for AFib. Moving to the next case is an ischemic VT case, 73-year-old. Actually, maybe I should stop here for a second and see if there were any questions by the panel or audience.
There was one question from Pete who joined that, but you explained it, but I think his question was specifically to, so he explained very nicely how you go up from a femoral region when it's smooth, but his question was when it's not going smoothly, what tricks you have? So
usually just rotating the catheter without any deflection will do the trick. So ICEs almost never have a problem. Obviously, you know, in medicine, we never say never. If there is, maybe the patient has some anomaly, it doesn't go up, then you use fluoroscopy. I can tell you that, you know, over the past 3 years that I've been doing this, I think I had only 2 cases where I had to use fluoroscopy because I was worried that maybe patient had some obstruction that was not known, maybe had a you know, filter or something that was not mentioned in the history. And then if you're going through the left side, the angle between the with the IVC and iliac is more acute than the right side, and the bend that you have to go through is harder. So that's why I would recommend if you're using both sides to put the ice on the right side, I use only right side access port and only use 3 sheets, and all of them go through the right side. If the catheters are not going up, the ice did go up, but the catheter's not going up, you can pull down the ice and follow the catheter up with the ice. And oftentimes the tip of the catheter is gone into one of the branches. I have a video, but I didn't put it on this one, that you can pull them out. As I said, it's very rare that that would happen. And I see that Pete put another question, said, do you do this pacing method while ablating with continuous ablation, or do you do point by point? It's a point by point. So I stay on the point, and when it loses capture, then I move to the next point.
Yeah. There is one more. There is one more question. If because not everybody is using ice, especially in Europe, about
so my last
echo. So how crucial is ice in this case? So
my last case, I'm not using echo. So when I get to that, that probably would be answering some of their question.
Yeah.
Can I also ask a question? I salute you for doing this in a patient with a device, because I do zero fluoro for also all of my AFs, but I don't choose people with devices. I exclude them. Would you have a limit on how many leads you would accept? I mean, how confident? You only see a 2D display of the leads. So let's say if it's a CRT or a kind of high energy device, would that change your mind? How many leads would you find acceptable? And how many device cases have you done zero fluoro?
All my cases are zero fluoro. Most of them, especially the VTs, have devices, and a lot of them have CRT. So to me, the number of, and I have had not even one case where the lead was dislodged. My concern is really not about the number of leads, but how fresh the leads are. I mean, if the leads are fresh, done within a month or two, I would probably avoid doing that. You could dislodge them even with fluoroscopy. So that's just the fact of it. An RV lead and LV lead, they're not going to be dislodged. It's really the RA lead is just the way the U shape that it creates. Sometimes the sheet tangles with it and pulls it down. But I do extraction also, and these leads, 6 months, 7 months, a year out, it's very difficult to take them out. So these are very stable. And as I said, if you know that the leads are there, which you do see them, as I just showed you in the case, actually this patient also has leads, so you will see the same issue. You look for them actively. So the LV lead is not a problem. RV lead is not the problem. It's the RA lead. So we'll look at it very carefully and disentangle them, not in the right atrium, but in the SVC. So before there is any downward force by the sheet on the lead.
Yeah, and I want you to make another statement for how to program the device if a patient, for example, or what to do, let's say, in any device, it doesn't really matter which device, how do you program them during the ablation? Especially with your pacing kind of trick that you pace to capture the A before you ablate. What do you need to do to not having the reed switch activated at a given vector? And that I know from our experience that is quite different from which company make is the device. So what's your solution there? What do you do?
So if the patient is not dependent, we just put a backup pacing, VVI pacing. If the patient requires pacing, either because of heart block or because profound bradycardia, we'll program it in a non-tracking mode, a DDI 60 or DDI 70 or something like that. For VT ablation, if the patient is dependent, a lot of them have low blood pressure and they need an atrial kick. So I would keep them in the DDD mode, so to be synchronously pacing during the case. If they're not dependent, I'll put them in a VVI backup mode.
Okay, so maybe I could add for that a little comment, because it really greatly depends on, and maybe you can discuss it with me. We have actually tested all kinds of makers of devices, pacemakers, ICD, CRT, anything you can think of. And we found that depending on the vector that you apply, in some places the reed switch will be activated. In some makers, it's going to be in every magnetic field direction. And we tested it at 0.08 Tesla or 0.1 Tesla. And in some of them, it's only coming on at some vectors that just somehow interact with the box probing. And what we learned is if you want to avoid having suddenly some V pacing happening, is to program the ventricular lead capture the output so far down that you cannot capture at all, which is extremely safe for someone who is not pacing dependent, of course, and in someone who is, that you have to have a different pacing lead essentially. Yeah. So I feel that you couldn't hear me anymore.
Right. No, I could. It's pretty clear. All right. Well, thank you very much. So yeah, this case is a 73-year-old gentleman, African American. Hello. Can you hear me?
We can hear you, Pedram.
Okay, good. So this is case number 2. It's a patient has a coronary disease, had PCI 2018, ischemic cardiomyopathy. EF was read as 15% outside hospital. Hello? Okay, established post-dual chamber ICD and had a history of sustained monomorphic ventricular tachycardia, was previously maintained on amiodarone. However, he subsequently developed pulmonary fibrosis, and that was a stop and was transitioned to mexiletine. He presented to outside hospital with monomorphic VT, which was relatively slow at 160. They had to externally cardiovert him, and they sent it to our hospital. We did the angiography. The stents were patent. While he was in hospital, he developed another bout of monomorphic VT, which was captured. So this is his baseline electrocardiogram. And this is his VT, which is a very wide left bundle, superior left axis morphology, suggesting somewhere infraseptal with the structural heart disease, probably anterior aneurysm of some sort. As you can see, very poor R progression. Also Q is inferiorly. So I will skip the access part of this and groin access and navigation, and I'll start with the transeptal just to highlight the questions that were asked. So the catheter is going up. As you can see in this case, the angle between the iliac and the IVC was very acute, but definitely navigatable. We're at the level of the liver now. Now here is a little bit difficult going in, and sometimes that happens because of the eustachian valve. And all we have to do is that turn the catheter away from the liver and then do an anterior deflection, and eventually we'll bypass the eustachian valve, be able to get into the right atrium. So you can have a nice view of the right atrium SVC using a decapolar catheter. This is a deca-nav navigation catheter to create the right atrial anatomy. And now we're going to put the long sheets in the SVC. You see what you're seeing here is the right atrium, the right atrial lead again. And in a second, you see the wire, the J wire is going up. And we'll push the sheet over it in a second. That's the sheet coming up right there. Now this is probably too deep. We don't have to go that far. We'll pull it down in a second. But the wire comes out and we'll flush the sheet. Again, heparin is given. That's the flushing. So we put the needle, the catheter's coming down, and right about there, it tangles again with it wants to tangle with the right atrial lead. And again, before dropping the catheter into the right atrium, we'll untangle it there by a clockwise rotation. And you can actually follow it very closely. So it's not, and it's released right there. Now that it's released, we'll pull the sheet down to tent the intraatrial septum. We'll change the deflection of the ice so that we get a better view of intraatrial septum. And right about there, so we're kind of in the mid right atrium. He has a sliding PFO there. You can see it. Try to avoid that because it's too superior, may limit our access. Now you have pulmonary vein views here. For a VT ablation, you probably don't want to go that far posteriorly because the mitral valve is an anterior structure. So I tried to go a little bit more anterior. So the sheet went through, dilator is out. You can visualize the tip of it, and there is no danger of damaging the opposite wall of the atrium. Once that's done, we have to, so this is actually the crucial part of the for VT procedure is that how do you direct the sheet into the left ventricle and how would the catheter, and that requires very diligent look with the ice. So what you do is that you pull the ice down at the level of mitral, which I'm going to show you. You have to visualize the tip of the sheet as you push it in, because otherwise you can push the sheet very easily into the appendage. So this is the mitral annulus right there, and you can see appendages right there. So if you don't look at this and just push the catheter in, you can easily go and perforate the appendage. But you can see very well the catheter. So we bend the catheter down towards the mitral annulus and then push the whatever diagnostic catheter you want to use through that without any danger of perforating any structure in the right atrium. So in this case, I'm using a decapolar catheter. It's the same decanav that I mapped the right atrium. You don't have to. You can use the RMT catheter or you can use the pentarray. Sometimes I use pentarray. And I'm going to sped up the image videos at this stage and quickly create a electro-atomic voltage map of the left ventricle. At the same time, obviously, you move the ice to the RV and start following that. There you go. So it goes into the LV. As you can see, a very good view of the left ventricle. You see the pap muscle. This is the anteroseptal wall. This is the posterolateral wall. And this is the catheter, decapolar catheters coming down here. Sometimes it gets tangled in the mitral apparatus, so you have to pull it back, bend the catheter, rotate it to release them. So in a second, you're going to see that. So the catheter is bent in a U shape, so the tip is not traumatic. And then once it's released, you can move it around. So we map we know where the apex is, where the anterior wall is. And we continue monitoring the procedure with the ice as we're mapping. For the rest of this VT mapping, I'm going to not show the ice images or they're very small in the corner, but throughout the case, we'll monitor the location of the catheter and contact with the wall. So very large left ventricle, as you can see, low EF. He actually had a smoke in the left ventricle. Large area of anterior anteroseptal extending inferiorly of a scar. Patient is spontaneous ventricular tachycardia, which is a left bundle, superior left axis, which is the clinical VT. Relatively slow, the cycle length 535. We're able to maintain his adequate perfusion pressure with inotropic support, and we continued mapping. So here you see the map is changed from voltage map to activation mapping. And we'll use the same catheter, continue the activation mapping. We were suspecting, based on the morphology of 12 leads, to have an exit size somewhere close to the infraseptal region. So I'll start with that area first. So if we have nice mid-diastolic potential right there, it matches what we thought would be the exit side, which is a septal, infraseptal region. And so we switch the DECA with the ablation catheter. Patient is still in VT, cycle length about 530, 540, and we start ablating, creating a line going through the scar and transecting that exit site. Those other dots you see are those lavas and late potentials, which we mapped during, so we'll try to get those ones as well. Creating the line. I usually try to draw the lines through those lavas. And again, the wattage is 50 watts. And right about there, it terminates as the line is completed. I continue, obviously, with the substrate modification. And he has a huge amount of a scar, and we marked multiple points to go back and ablate. So we completed that. But that was kind of the gist of the procedure. So I don't know if there was any questions regarding the VT case that the panelists want to ask.
Oh, my microphone works again. Can you hear me?
Yes.
Yeah, perfect. What's in the decision making of how you approach it? Would you always go transeptal? Would you consider going retrograde? Then you wouldn't have to deal with any transeptal puncture, no wires in your way. What would make you decide for one or the other way of doing it?
I generally go transeptal with one or two exceptions. The reason is that there's always calcification in aortic root, and which I cannot see with echo often, or even if I can see, I can't avoid disrupting them. And there's always a risk of a stroke going retrograde. I can pretty much with RMT, it has sort of unlimited degrees of freedom in terms of where we can go with it. So I never had problem reaching any area in the LV through transeptal, and it's relatively safe, because we do it routinely for AFib and other cases. So I have no problem. I actually worry more about retrograde than the transeptal. With some exception would be the cusp VTs. I will try transeptal, but oftentimes the catheter stability is not ideal, and it may be better to go retrograde and do that. The problem with the retrograde and RMT, as you know, is the flow often pushes the catheter out of the aortic annulus, and it requires using a lung sheet into the LV to give some stability, or creating a loop in the LV and then pulling the catheter up. So each one of them has its own plus and negative, but generally I go transeptal.
Now, my non-robotic or non-magnetic friends would say, you've already mapped the entire ventricle, the tachy, manually, you're already there, you're sterile. Why don't you not open a normal catheter and just do it with a normal catheter? Why changing at that point for the last, let's say, I think you probably didn't ablate more than 5 minutes. Why changing to magnets at that point? What makes you do that change? Is it
the mapping was not an ablation catheter? It was a DECA-NAV catheter. It was a diagnostic catheter.
Yeah, but that is a manual map that you did, right? So you've done, or did you? So now again, I'm trying to play devil's advocate. So if you've done all the mapping, you've identified your target, and you change to magnetic navigation for the last 5 minutes where you just deliver the energy. What makes you do that? Why don't you just go for a manual ablation catheter at that point?
So the reason I use a multipolar catheter, and sometimes I use a penta-array, is the resolution for finding this delayed potential. With the 4 millimeter or 3.5 millimeter diagnostic catheter, often you can't see those late potentials. So I prefer mapping with the multipolar, narrowly spaced catheter. Now, why don't I go there is because I actually feel that one of the biggest benefits of RMT for VT ablation is the operator sitting outside. So I can do pace mapping, I can do entrainment mapping, myself while I'm sitting there and moving the catheters. And that's the main reason. And then there is a fatigue factor as well. So this, yes, it was 5-10 minutes to break this VT, but as you saw, the patient has huge amount of a scar, and to substrate map this would be an hour procedure. So sitting outside, comfortably and methodically going after every of these delayed potential, all those blue dots and purple dots that you saw, I have to go after them and make sure they're non-capturable, make sure they're non-inducible. Sometimes you go from VT1 to VT2 to VT3. You have to remap them, paste map them, and train them. So it's a long time, and it's much easier when you're sitting outside and you can move the catheter where you think the exit point is and paste map it. So I'm actually, that's the main reason I go with RMT, not necessarily the initial ablation at the VT exit side of the VT1.
So you must feel that a magnetic small electrode mapping catheter would be the perfect addition to your kind of workflow, right?
Absolutely.
Do the mapping itself also with small electrodes on the magnetic base.
I believe that's sort of the next frontier. If the company wants to spend money, it's sort of a diagnostic multipolar narrow lead space or small tip catheters where you can actually resolve these small voltages.
Can I ask you actually the same but in a different way? Because from the very beginning of a robotic Vt ablation, it was never published on this way, but when we have this anecdotal conversation with each other, we all had an impression that when you look at the maps that you do manually, even with these diagnostic catheters, you have much better reach with remote catheters. So during your ablation, you never have the idea that actually you haven't mapped perfectly with the diagnostic catheter. In other words, do you ever have the feeling that with the remote catheter you have a better reach and you gain access to parts of the LV that you didn't actually map during your manual?
Yeah, actually, I didn't. So if you go back here, when I pulled the decapolar catheter out and put the ablation catheter back in, which is right about here, if you look, I'm not ablating here. I'm actually mapping because there were some areas where I wasn't confident that the decapolar catheter had adequate contact. You can see it on the echo. So look at the bend of the catheter. There is no way that you can, reach these areas with a decapolar catheter. Just give it 1 second till it comes out of the pap muscle. They're right there. So if I stop there, maybe just right. Oh, sorry. Anyway, what I want to show is that it's very difficult to reach the bend of the catheter is not so that it will allow you to, especially with this large ventricle, to be able to bend it, and the bend will be floating in the ventricle. There's no way that it would reach here. But with RMT, you can do it. And that's what I was doing here. I didn't talk about it, but before starting ablation, I was actually mapping with the RMT catheter.
Cool. Okay, let's hear what happened in the third case.
So the third case was an SVT case. It's a very interesting case. 74-year-old female had a history of atrial tachycardia and fibrillation. Actually, for years, been on Eliquis and hypertension, hyperlipidemia. Continued to complain of palpitation. And whenever we put a monitor on her, we couldn't capture anything. And she ended up getting a loop recorder into 2020. On the loop recorder, what she had was SVTs that lasted for a few minutes, a heart rate of 160, 180, no atrial fibrillation. And we put her on metoprolol, really didn't do much in terms of reducing the episode. It was very symptomatic. An interesting thing is that she said that I could terminate this episode by holding my breath and doing vagal maneuvers and things like that. So all of a sudden, they sort of painted a different picture of this so-called atrial fibrillation. This is her baseline ECG. This is actually a few days ago, 6/9. There's no delta waves Nothing dramatic about this, maybe a slightly rightward axis, but echo was normal. So answer to your question that you were asking, what do you do if you don't have ice? So I did that. Most people would not open an ice catheter for a right-sided atrial tachycardia or SVT. So that's what we do. So the sequence of events is the same. So you put you get groin access, you use some sort of a ablation catheter where you can map. In this case, I'm using the Decanav again. Slowly go to the right atrium. Obviously, since you don't have a nice ice guidance, you just have to be gentler, be mindful of the structures. And, you look for things that you usually need to put your catheter in. So His, for example, as you can see, I'm mapping for the His on the septum. This is right bundle showing up here. Pull catheter back, again, create a nice His cloud. That's beginning distal His. That's sort of proximal His there. And local, again, for AVNRTs and SVTs, I very diligently map the CSOs, the septum, the His. Obviously, that's crucial part of this. So it has this posterolateral branch of the CS. You see mostly V actually on the distal. We'll pull it back and then go to the main branch of CS in a second, which will be going up this way. So now I have all the structures that I need to have. We'll leave the image in RAO, LAO, so as if you're looking at the fluoroscopy, essentially. Now we push the quad catheter up there. Again, these are non-nav catheters, so you don't see the full length of catheter, but you see the electrodes on them if you created adequate matrix. So you have to create some matrix in the ventricle. So that goes into the ventricle. So that's the RV catheter. The next catheter going up. And as you can see, they move this kind of funny way because they're impedance-based, really. These are not navigation-based. But when it gets to the atrium, you see atrial signal, as you can see here. This one going to be placed over the His. And very easy to put it over the His because we already marked the His. So all you have to do is that rotate it clockwise and counterclockwise till the catheter sits on the His. And the last one is a right atrial, so we'll put it on somewhere lateral, high right atrium. So when everything is said and done, you have 4 catheters placed, and you have RAO and LAOs as if you're looking at the fluoroscopy. So that's how HRA, RV, CS, and His catheter. So we did that, and then we started doing an EPS study. So this is a baseline measurements. As you can see, HV is normal, 48 millisecond. Nothing funny about the baseline. Ventricular pacing showed concentric atrial conduction with the VA jump actually going from 600, 390 to 370, goes from 158 to 234. So I already have some suspicions of about maybe AVNRT is the cause of this. But interestingly, when we do atrial programmer stimulation, patient goes into this thing. Very slow tachycardia actually has a PAC that initiates this. About 550. This is patient not on isopril, by the way, so relatively slow. Sometimes even less than 100, be 600 millisecond. But they're stable and reproducible. And ventricular overdrive pacing has this VAAV response. Obviously, activations from HRA downward. And this is termination. So this is the AT and this is sinus, and the activation is fairly similar actually to the sinus. Not identical, but very similar. And if you look at unfortunately we had noise on the surface ECG, but if you look at the P wave of AT and P wave of sinus rhythm, they're similar, but slightly different. I mean, there's a biphasic here. There's a biphasic in the AVF also, which is not. So it's definitely not sinus tachycardia. It's not a sinus reentry tachycardia. It's an atrial tachycardia somewhere from the roof of the probably crista area. So now it's easy. You already have a decapolar catheter there. What I did is that I put a non-nav decapolar in the CS, and I used that deca-nav, which was in the CS, for mapping. So I don't have to open a different catheter. As you will see, as the patient constantly goes in and out of it, we have to reinduce it, but it's completely reinducible. This is the tachycardia, but then it terminates. I'm gonna sped the movie. There you go. So we start pacing protocol to induce AT and continue mapping when it's inducible. Same cycle length, about 500-600 milliseconds. And very quickly, this image comes out, which gives you very nice local activation in the lateral aspect of the crista. So it's your typical run-of-the-mill crista terminalis. Definitely we're pre-P waves here, activation on the distal. So that seems to be the location of interest. We try to bracket it, and terminate it there. So we reinduced again. So a bit anterior to the early activation, posterior, inferior, very nicely localized to that area. And in a second, I'm going to put the tip of the catheter over the earliest activation. And you can look at the unipolar. You can see it's the QS, very nice local activation. So I think there is no doubt that this is a crista atrial tachycardia. The question was that, is this clinically relevant or not? The patient was not on isoprel. This was continuously reproducible. So, and the patient had palpitation. So we had no choice but going after this and ablating it. So obviously we mapped the phrenic nerve. We had this white dots. So ablation catheter, this is irrigated ablation catheter, by the way. Mapped the phrenic nerve, we had adequate distance, and then we ablated it, which accelerated it and then eventually terminated it, made it non-inducible. After that was done, we did program stimulation, and the AT was not inducible. So we started isoprel and repeated the program stimulation with isoprel, and this happened. So now this patient has a short RP tachycardia with a septal VA time of a little bit prolonged, 98 millisecond, but at the rate, cycle length of, at the rate of about 200 beats per minute. A lot closer to what we detected on her loop recorder. Ventricular overdrive pacing, and trained it obviously with the VAV response, prolonged the PPI minus tachycardia cycle lengths is 472 minus 318. And so this was clearly AV/RT, probably atypical AV/RT given the longer VA time. So now I know that people are worried about using irrigated catheter for AV and RT ablation, and I don't think there is any need to worry about it when you're using RMT. This is a misconception that the tip of the irrigated catheter is hotter or creates. Now, for any given wattage, a tip of a non-irrigated catheter is hotter, and but the reason we use irrigation is that we can actually use higher wattage. We don't need to use higher wattage. I usually start with 20, 30, and if I don't get the result, then I go up higher. So you don't need to open a different catheter. You can use this. And this is, again, another benefit of using RMT, because you're sitting in the control room. We started ablating very low and ventricular down here and no response. Now I have to go more atrial and more cranial, which obviously will get me closer to the His cloud, which we created very nicely here. So I'm going to use the RMT catheter to map that area and do it very diligently. So going, this is not ablation. We're just mapping the for His, and you can look here. This is a mapping catheter. There's no His there. and gradually moving the catheter cranially. No hiss there. Even there's no hiss, and that's ventricular. So we're clear in this area. So very clearly, you're sitting next to the monitor. You can look at it yourself. You can move the catheter, be sure that the catheter is stable. And then when it's stable, I came on ablation here, and you see patient went to junctional. So you get junctional, ablation on, junctional again. Ablation on again. And junctional. So we continue.
How many watts you say you're doing this with?
It says here 29, 30 watts, right? And then return to sinus. So stayed on the last ablation, we stay on till we get back to sinus and junctional results. There you go, ablation on. Junctional. Obviously, temperature is useless at this stage because it's irrigated. And return to sinus. So move the catheter downwards, and then we repeated the program as Stimbit and without isoprel, and it was non-inducible. Neither the AT nor the AVNRT was inducible. So this is an example of a right-sided tachycardia where we didn't use ice, and you still can use the RMT and the fluoroless method. So I think that's my talk. Thank you for your attention, and I'm curious to hear your questions and comments.
Yeah, thank you, Pedram. Excellent presentation and great cases. I also have a comment. Yeah, if I may start with a comment, because I confirm that you say, actually I do all of my AV nodules with magnets, not fluoroless, but that's another thing that we can discuss in a panel discussion. And just one addition to the catheter choice. I also always do, actually I use Go-tip catheter, the one which is available on the market. And I always start in a non-irrigated mode. So even if you have an irrigated catheter, you can choose between non-irrigated or irrigated mode, depends on your priorities. I like to have temperature feedback at the beginning, and exactly how you say, if you have difficulties with energy delivery without changing the catheter, you can switch very easily to irrigated tip, and this is a very nice thing. I do it, I did it already manually since more than 10 years, and it works quite good on this way. Let's see whether we have other questions from the audience. Not at the moment. Maybe Sabine, some comments?
I think, all the changes we started with SVT ablation a long time ago was the first procedures we did magnetically. So I think what I think you highlighted very nicely is that you're sitting in front of it and you see every single beat. You can judge the stability by, even if you wouldn't use 3D mapping, you could just judge the signal itself not changing, so that when the catheter flips, for example, when the patient takes a deep breath, that this would make a big difference in the signal, of course. Now I just got interrupted. I wonder what the sedation was for this patient. How do you manage that the patient doesn't move when you do these kind of ablation? Of course, that would be, a magnetic field is stable, but are they sedated? How do you sedate patients?
So my approach is that I know this may be controversial, but I want patient to be comfortable. So I start with MAC to gain access, and I do a full EP study to see if the arrhythmia is inducible or not. If the patient was not inducible, then I will stop the propofol and wake patient up. And it's much easier for the patient because they didn't have to suffer through access and those sort of things. So they were comfortable, the catheters are in. And then I try to reinduce it. Obviously, what you lose here is that there are some ATs, as you know, that the sedation will prevent it. But if rarely that happens, then I can talk to the patient later and say bring him on, but don't do any sedation and do with a local. But my general approach is to start with MAC, induce it. If it's inducible, continue with MAC, finish the ablation. Not inducible, stop the MAC, wake him up, and then try it re-inducing again.
Yeah, I think sometimes sedation can be quite an enemy in SCT. So,
yeah, that's what you lose. I see some questions. I think Pete asked a question, said choosing a different mapping system understands.
So, Pedram, can I interrupt you?
Yeah.
I just wanted to make a comment about that question. If you don't mind, because it has some philosophical consequences as well and strategical consequences. I saw that question too, but I recommend that we do it at the end. We discuss this at the end during the panel discussion, because I think it's a very important question. It's very important that not only the speaker, but all of us can tell the opinion about this.
About the timing of total procedure, we actually measured it. It added at the beginning when you switch to the fluoroless about 10 minutes to the procedure. And after 30 procedures, that 10 minutes goes away. So it's really not significant. Hopefully we'll publish it in the upcoming journal. And
what are the total times? Because of course, adding time in a certain center, that is also very important, but we also have to understand the limitations. So
PVI time, my PVI time average is about 60 minutes to hour 20 minutes.
Very nice, thank you. So I think we should move on also because of the time. And I'm very happy to present the next speaker, Dr. Percell, who is an electrophysiologist at the Bryan Medical Center at this moment. He had fantastic education in Johns Hopkins Medicine, Baltimore, and then he completed his residency at Duke University, and then he moved to North Carolina. He moved to Florida, and he completed his electrophysiology fellowship at the end in Boston. So it's a very complete and fantastic CV, let's say that, and we don't expect less than a fantastic presentation about the fluoro reduction in robotics. So the floor is yours.
Okay, thank you. First of all, I'm very happy to be here. I've been very enthusiastic about doing zero fluoro, or what I like to call sans fluoro procedures. Been sans fluoro since 2016. And I'll take you through, first of all, some data regarding why we should be doing this. And then we'll talk about how you can go from manual to actually benefits of robotic techniques. So just going forward, most of us think that fluoroscopy is indispensable. We have to have it. I say to you, that's not true. I mean, we're using technology that's been discovered centuries ago. I mean, since 1896, everybody knows about the stochastic and deterministic effects, and we've been using our lowest reasonably achievable. This actually was started in 1977. I mean, it's 2021. We should be going forward, okay? So when we talk about the negative effects of radiation and fluoroscopy, we all know about the different cancers, thyroid, skin, brain, neck, in terms of also stroke and carotid disease. When we look at what happens, people get cataracts, hypertension, chromosomal abnormalities. I mean, the list is growing and continues to grow. And for us, not only do we have to worry about radiation to ourselves, but what about our patients? I mean, we're all EPs here. So not only do we do things like ablation for AFib, AVNRT, and VT, but we also have to worry about radiation from our CRT implants. So if we look, I mean, AFib ablations in the past, you were getting a significant amount of radiation exposure. This is for our patients at 16.6 kind of millisieverts. And for us, it was at least 3. Now, when we come with robotics, yes, we're outside of the room. We don't get this anymore. But what about our patients? What about the nurses? What about everybody else who still has to be in the room? And to put this in perspective, if we look at this in terms of how many actual chest x-rays, one chest x-ray is worth about 2.4 days of background radiation. If we look at a typical EP study, and this is not including the CT that you may get prior to, say, an AFib ablation, this is the equivalent of 300 chest x-rays at least, or 2 years of background radiation. Moving forward, we don't see this much anymore, but this was one of the main reasons why I started working toward becoming a SANS fluoro operator. I had a young man in Boston, okay, he had been ablated at another institution incompletely for a pathway, and he came to us because he had a lesion that looked more like the guy on the left. And it wasn't even successful. So at this point, I started getting a little more serious about trying to, one, decrease radiation to myself and to my patients. And of course, this wasn't an EP study and it wasn't mine, I promise you. But this guy, you can see the results not only early on at about 2 months, but 6 months and even 2 years later, you can see skin breakdown, desquamation, and all these type of things. So we shouldn't, put radiation as saying, oh, this is basically safe, because it's not. Okay, no amount of radiation has been determined to be safe. Otherwise, we'd all be doing ablations manually, in our bathing suits. But I digress. Going forward, even if you look at not only just EP docs, but what about our interventional friends and even radiologists, interventional radiologists? Death rates from brain cancer are 3 times higher than those who actually don't use radiation. Even as little as a sievert or less than a sievert can increase your risk of having background tumors and these kinds of things. Okay. We say, well, we can wear lead hats, lead aprons, even lead forearm shields, and even down here in terms of skin shields, or shin shields, shall I say. Still, no amount of radiation has been determined to be safe. All right, switching gears, going forward and talking about fluoroless, zero fluoro, or what I like to call SANS fluoro radiation procedures. Okay, 5-6 years ago, there were only a few case reports, and most of these were in pediatrics and pregnancy, and you'll hear a lot about near zero or minimized. But there are actually very few randomized studies that look at pulmonary vein isolation procedures for atrial fibrillation. And of those, most were, very small studies or single center, very few operators, or if any operators, they were very experienced. So this is one of the main first procedures or first studies. Bulova had a single center trial with less than 100 patients that first showed that, hey, randomized zero versus fluoro, there was no difference. It's feasible and it's safe. And Natalie's group did a randomized study with, this wasn't for AFib, it was 6 centers in Italy, but it was about 260 patients, mostly for SVTs. It showed no difference in the procedure length time, but much different fluoroscopy times. And actually, when they extrapolated, it actually showed benefit for if a young woman at age 15 had a fluoro procedure, she actually would lose about 2 weeks of life if she made it to age 80. So this kind of got everybody thinking, okay, how can we do more either zero or minimal fluoroscopy procedures? Now, this was actually now almost 5 years ago. This is where the whole SANS fluoro comes from. As a kid in the 80s, You know, I remember, who was it, Nancy Reagan saying, say no to drugs. So I start saying, say no to fluoroscopy, hence sans fluoro. We did a study. I just gotten out of fellowship. My back was hurting. And 5 out of the 12 EP docs in the state of Nebraska had developed some kind of radiation-induced cancer. So again, this stepped up my level as saying, hey, I need to somehow reduce my fluoro rates. So what we did was we looked at approximately 50 patients, 22 fluoro, 22 non-fluoro, and there was no difference, okay, in our fluoro patients or our non-fluoro patients. And we even included cryo procedures in that small sample. Now, and not to be repetitive, but the key to doing AFib ablations, especially, yes, right-sided ablations are what I think most people should start with, but is learning effective ICE techniques to do transeptals. So as Pedram kind of already said, Dr. Kazemian, you need to have good appreciation of your anatomy as well as good ICE techniques. And way back when, we didn't have these catheters that we can see so well. This is actually the Visigo catheter. So you can see the actual electrodes very nicely. And this is looking high up the SVC. Here is your left atrium, your right atrium, and you'll see the actual foramen right here. Now, in our next slide, you can see where we're actually pulling it back. So this is one of the first kind of examples that most patients or most operators should get to in learning how to do this. And as Dr. Kazemian said, when you drop down into the actual foramen, what you should look to aim toward is aim toward the veins if you're doing a PVI. Now, if you're going to do a VT ablation, you want to look anteriorly, bring in the appendage over here, or actually aim toward the mitral valve. And he did an excellent job of showing that. But even when your images aren't the best, and we all know ICE can be technically difficult, it's easy to see, yeah, we got bubbles on the left side after we crossed. And finally, you can see the catheter coming across. Okay, but having visible sheets, I was asking for this for 3 years prior to development, and it's nice that we have one of those now. So going forward, more on the zero fluoroscopy studies. The largest probably zero fluoroscopy studies that have been done. One was done by Rosemia's group up in Chicago, a 5-year experience. Now, these were all manual though, and only about 20% of the patients in this study were AFib ablations. They had SVTs and also a lot of VT in this case. We did our second study in which we looked at more than 1,000 ablation procedures. Like I said, 1,000. And it's been the only large series that has included RMT. And we use multiple mapping systems. There was a question about that earlier, whether it's Biosense or whether it was or the Abbott system. And we've even done some with the Rhythmia system as well. We use RMT, RF, and cryo. So this was kind of our seminal production. When we looked at all the patients, we used our first 200 or so that we were still using fluoroscopy, and we compared them to ones that we used sans fluoro. And it wasn't cherry picking patients if they had devices or not. This was basically all comers. So it was a total of 1,200 procedures in 816 patients. We followed them up for 23 months, okay? And this is basically what we found. The main take home from this was that, yes, whether you're fluoro, sans fluoro, SVT, VT, AFib, it did not matter. The fluoroscopy and exposure time was much less, as you would expect, okay? And when you look at vascular complications, really, they were really small. And in this case, maybe 3 patients overall got CTs prior. So that again points to why ICE is so important. All right. There was one patient that I could not find a left superior pulmonary vein on. So I got a CT on him afterward, and it turned out, she was a woman. She had lung cancer. And when I went back to the reports, it was actually tied off. So if you have good ICE techniques, I never do routine CTs, only if it's a third or 3-do. We had no strokes, there were no deaths, and the amount of serious cardiac complications were really low, less than 1% in each group. Now, just skipping forward to going to get to the meat of the matter. But feasible is one thing. What about your efficacy? Now, when I looked at just the AFib patients, because we had almost 600 people that were getting PVIs in this case, it didn't matter whether it was RF or cryo, fluoro or sans fluoro, RMT or not, patients did approximately the same in terms of their AFib survival, AFib-free survivability. And when we divided it again, whether it was women or men, I mean, in the past, most of the larger trials have said women don't do as well as men. That didn't come up in our case. Whether we looked at cryo, whether we looked at RF, RMT, it did not matter. They did about the same. And going back to what was a question earlier on patients who actually had devices, right? I looked, and the group looked at implantable loop recorders, patients with pacemakers and ICDs. Their AFib survivability, as we said earlier, was not different. And we actually got to check this because most of our patients were on remote monitoring all the way out to almost 40 months with a good amount of persistent patients. Still 60% of patients were AFib free. Now, it's always a good idea to use cases, right? And I tried to use the Obama pause there. And I had to change this up on the fly so I wouldn't duplicate Dr. Kazemian's presentation. And it was an excellent presentation. I think that he showed a lot of the technical aspects in terms of what you have to map, how you have to get there. But in terms of sans fluoro procedures, we had a 48-year-old woman who had atrial flutter, typical atrial flutter, was symptomatic, failed cardioversions on amiodarone, and she was not small, okay? She was morbidly obese. She was 600 pounds and had lost 50 pounds. She was 550 pounds. She would not fit on a table. So we actually, unfortunately, we had to do her manually, but we did her sans fluoro in her hospital bed, okay? So once I started realizing, hey, and we wrote that up, we can do sans fluoro procedures on patients manually this big, we need to come over and do more robotically. And this was her kind of ablation set lesions. And somebody asked a question about, can we use other mapping systems? Yes, I will show you. This was actually the Abbott mapping system, and we will show you some of the biosensor cardio as well. Now, going forward, another case, we talk about devices, and I think Dr. Sabine Ernst was asking, well, how many leads do you feel comfortable with? This was a 76-year-old guy who had atrial fibrillation, failed multiple cardioversions on amiodarone, had a low EF, 20%. Typical guy would get, right? Ischemic cardiomyopathy, and had multiple episodes of atrial fibrillation. And my older colleague who was retiring said, okay, you're going to need to have a pulmonary vein isolation procedure, an ablation. Well, this was his chest x-ray, okay? So I'm counting here, 1, 2, 3, 4, 5, 6 leads in the guy. And my older colleague who's retiring had been seeing him, 6 months ago and was basically kicking the can down the road. And this was a very busy day for me. I'd had 3 PVIs to do that day, and I knew this one might be difficult, but I didn't actually remember that he was the guy. So it was a little bit more difficult crossing the septum, but again, we did his ablation without problems. And I actually did a posterior box on him because he was a persistent guy, and we isolated his veins. And this was his chest x-ray after. No lead dislodgement, not his LV lead, not his RVICD lead, nor his optimizer leads. And we wrote that guy up as well because he was the first guy who had an optimizer with 6 leads in the heart. But this is getting a little bit away from kind of the main presentation. Now, the last case I think I'm going to show you is a case of a redo, okay? Frequently, you'll see, all right, do we do the first case? Can we do a second case with robotics, with fluoroscopy, pre-procedures? Well, this was a case I just did 2 weeks ago, and I think Brian Pullman is on the line, and he might have even been there, or Dave was there from Stereotaxis. 69-year-old guy who'd had a PVI 2 years ago and actually came back with this. Okay, he'd been misdiagnosed as having sinus tachycardia. Well, for our EPs there, we can see this probably isn't sinus tachycardia. Okay, I was very suspicious that this was an atrial tachycardia, especially since he'd had a PVI in the past. Well, this was actually my ablation lesion that we did with RMT. We didn't show many of this, but much of this in Dr. Kazemian's presentation, but this is what I like to call a cloudwork orange. Okay, when you look at this, yes, we use our Cardo or our Abbott, and we look at impedance drops or time and things like this. But when you look at the watt seconds, you can actually see that this is the left atrium. This is the left atrial appendage. Okay, when I checked all of his veins and the posterior wall, it was completely quiet. And I did it with the pen array, and I was asking my rep, I'm like, hey, is this pen array working? Because everything was completely quiet. It was devoid of signal. But yet he continued to be in this atrial tachycardia. And most of you will probably actually pick up on this already. There's an area of early meets late here, okay? So you probably have already guessed what this is, and the next slide will hopefully bring this home for you. All right, so this is just a basic propagation where we're looking at the left atrium in an AP view, all right? And here was the early meets late again, but this is the mitral annulus here, and you see that it propagates in a counterclockwise manner. Let's see if I can get it to play again, all around here and goes back up, okay? Clearly consistent with what looks like a mitral dependent counterclockwise flutter. Okay, so in this particular example, you can see my ablation lesion set, and it may look like there are gaps here, but when you go back and look at this, there does not appear to be much in the way of gaps. And we were able to terminate this by coming across to approximately right here when we got close to the mitral annulus. And here is actually the counter raw data. Here's the CS, and we broke it here during ablation. So I wanted to talk a little bit about pitfalls. We'd had a brief discussion earlier about going transeptal versus going retrograde aortic. Now, this was a case that I think we published in EP Lab Digest just 3-4 years ago. And yes, this was done obviously with RMT, and this was also a sans fluoro case. Well, some of the pitfalls you can get from going retrograde and not using any fluoroscopy is this is actually a large atretic saphenous vein graft. So by not mapping earlier, because I tried to do this whole case with just the Stereotaxis catheter. Oh, let me go back here. We were actually in this vein graft, and it took me a while to figure this out until we actually came back and went down and crossed the aortic valve. And this is the area of scar that you see here. And this is actually in another projection. No untoward events happened because this vein graft is known to be completely occluded down here, and patient did well. But these are some pitfalls that you could actually run into. So almost always I use a transeptal approach. Okay, so future directions. All right, future directions. At this point, I've done one ablation in the last 5 years with fluoroscopy. And it was an AV node. And the reason why we did it was because the actual ablation, the actual mapping system went down in the middle of the case. Because I don't believe that we should go forward and say, well, fluoroscopy is okay. I think fluoroscopy should go the way of the dinosaur. And I think all of us should minimize the amount of lead that we use because of all of the untoward events. Now, with or without RMT, and especially with RMT, because we're not even standing and we shouldn't have to, our tools and our mapping systems are good enough that they're almost CT-like quality now. I think all EP physicians and staff should go sans fluoro or zero fluoro. And if you have the ability to use RMT, we should go ahead and do that as well. And we've also started a sans fluoro association for continued research and innovation. So this was more so a 30,000 square foot view. And I hope that it fosters us to have more discussion as to why we should be rid of lead and why we should be rid of fluoroscopy. And for those who do social media, you can look at us on sansfluoro.com and sansfluoro.doc. And hopefully for everybody who's going to HRS, we actually have a debate on why all AFib ablations should be sans fluoro. But with that, hopefully we'll take questions, comments, complaints, or whatever you may have.
That was fantastic, Robert. That I really liked it. Liked your enthusiasm. That's number one thing. And I really, really, really liked your tie. The tie is very good marketing. I think that looks amazing. And I think you're absolutely right. I think any EP procedure should be zero fluoro as much as you can for our personal motivation, for our personal protection, And I think that's why we need to start in getting people converted in a way. Because, people so far have always said, oh yeah, the patient only comes once or twice, it's not a big deal. The lifetime risk for patients is such and such, and it's very low. But you're absolutely right. Our lifetime risk, our professional lifetime risk, which is not only cancer, but it's also orthopedics and kind of, I think Pedram said that, ease of use is so nice. I love magnetic navigation because I just sit outside. I don't have to do much to bring my own exposure down. And I'm very happy. I'm using the system now for 18 years. I have significantly lower fluoroscopy times over nearly 2 decades to show that I'm not in the room. I just don't get it. And I think it's quite good. I just wanted to highlight, I think again, coming from the US with both presentations, of course, it's eyes. You have access to eyes, but lots of us have no access to eyes because it's just prohibitively expensive. I know, and I put something in the chat, that there is a reference how to do transeptors without eyes. If you have TOE, okay, but you can only do it without a TOE. So there are other ways of working around, but I think eyes is a great tool that could probably exchange the whole fluoro thing. Would you ever consider, and that's maybe a provocative question, but would you ever consider starting a case if the fluoro system, just for kind of safety reasons, would not be working at all? So would you, or even more provocative, would you do it in a non-fluoro room?
That's an excellent question. And I would. I think the only reason to have it is just all my right-sided cases, I don't use ice with, and I think you could do those in any place. I mean, I had to cover for, and that's just personal kind of thing. I had to cover for one EP in another state who had back issue, and they would line up 3, 4, 5 cases, mostly right-sided, flutters, SVTs, and they hadn't done any sans fluoro procedures before. So I didn't wear any lead, and I never do, but you could even do this portable. Okay, you could even do this portable. For right-sided cases, the risk of perforation and significant such that you would need to do a pericardiocentesis or something like that is so low that I don't think you need it. Now, for crossing the septum, I think that having a backup there just in case is likely, like a C-arm just somewhere near. But I have had cases, and this is the truth, where the rare, and I knock on some wood, it's been about 2.5 years since my last tamponade case, but even the patient had tamponade, we drained it with an echo, and still they got no fluoroscopy. So mostly I would say for right-sided cases, no fluoroscopy is needed, or ice, but left-sided cases, I would have it there just in case.
So I also would like to ask something, maybe it sounds provocative for all of the panelists, actually. And I must say myself, I've never been a fan of the zero fluoroscopy, and despite the very convincing results, but I try to look at all of these things and developments from the strategical point of view and also philosophically. And I completely agree with all of you. If you look at the strategy of, on a long run, eliminating fluoro from an EP lab, that kind of movement I would completely support. However, there are some issues that we have to discuss here because and again, I'm not the fan of using a lot of fluoro, but in a whole life, I just hate black and white things. So maybe I can start with an anecdotal things, actually two. One of them is two fellows of us, young physicians, and then they became seniors. And the other one moved to another center, and they just ebbed each other in a certain moment about fluoro times. So yeah, today I did a PVI 2 minutes, and the others sent back a message. I did a 1 minute 35, and then it went down, and in our case it went to the, and we arrived at the day of the zero fluoroscopy, and the guy just, and I know it's a mistake, but he didn't read the history of the patients very carefully, and it was a liver transplant patient. And actually, he perforated something in the abdomen when he put up the catheters. Of course, it was the wrong coincidence, but for me, it's just a very nice example showing the black and white is never good. I think you have to be always very, let's say, prepared for every scenario. The other anecdote is, because I also have a friend, an EP guy, one of my best friends in the past, who has thyroid cancer. So I completely support all of these movements. Now, but why I'm saying that avoiding fluoro will be difficult in the future, and I'm really interested in your opinion. It's something to do with innovation. So fluoroscopy is one of the, it's still the only direct and real-time visualization method at this moment in a EP lab, and many other things what we use, and just you showed are reconstructions and indirect maps. Now, when you look at the new developments like catheters from Adagio, Acutus catheter, complex mapping catheters, and PFA catheters, which will be maybe using different mechanics. Fluoroscopy very easily and very quickly allows you to implement that and learn that particular technique in your lab, while I suppose the workflow of the zero fluoroscopy guys is based on a learning curve, and you learned it with a certain technology. Even if you say that you can use Abbott cart or whatever, but they are always, they all based on the same principle. And then these new devices can be based on different principles. So my question is, for instance, Acutus. How comfortable would you be, guys, to put the Acutus catheter in a left atrium, moving in a super map, roving the catheter around? And I took this example because, especially when you look at Acutus maps, right atrial maps, they look real right atria, and the Carto maps, what we think right atria, are not even looking similar to the pathological right atria, let's say then.
So Thomas, let me ask you that. So I had the same concerns as well about this, back when I started. But if you think about it, there is not one anatomic structure related to EP that you can see on fluoroscopy. We're using surrogate markers for it. You can't see the septum. You look at the jump. You can't see his. We're looking at the sort of the peak of RV lead, for example. You can't see the SVC very well. You may be seeing, but the edge of the cardiac silhouette, you will say. So not all of these are surrogate markers that we look for to see it. With ice, you can see them directly. So you see where it's tenting. So it would be akin to sort of using a white stick to find an object and then using a flashlight to confirm that that's the right object. Why not use the flashlight right at the beginning and then not use the, but that takes a leap of faith essentially, and then gradually have to get used to that. Just to give you an example of this, so I had a case where a patient had double valve, mechanical valve, mitral and aortic, and had atrial septal closure device put in. So I would say, well, would be tough to do it with without the fluoroscopy. Actually, it would be tough to do it with fluoroscopy, because without fluoroscopy, he has only a small gap below the atrial septal device that you could see on ice. That's the only place you could go to that you're not going to be able to see with this. You can mark the location of the mitral annulus so your catheter won't drop in there. Actually, the mechanical valves are very bright with ice, so you can see all of that. So I think a lot of these are conceptions that we have because we've done them traditionally with the fluoroscopy, and gradually as this paradigm shifts to using ice, we'll realize that the actual visualization with ice is better. But it's not, I completely agree with you that if you doing a procedure and you feel that you're not comfortable, something is not going where it's supposed to go, the catheter is not moving up, it's not a matter of pride. I mean, use the fluoro. But in my practice, I said I used it twice. One was the gentleman who, his BMI was like 60. And I definitely didn't want to have any perforation. And I had difficulty going transseptal. I couldn't see the septum very well. And I used the fluoroscopy. At the end, I only went across when I saw the catheter with the ice. So again, I relied on it, but maybe I wasn't 100% confident. But I agree with you. It's not a matter of pride. If you think that there's something, if you can use a different modality to confirm the location of catheter to avoid a complication, go ahead. But in practice, that's very rare.
Yeah, Pedram, I not completely agree with you for two reasons. One of the things that I'm not looking at any anatomical not even landmarks on the fluoro, but I'm looking on the fluoro how my catheter behaves, and because that's the only direct one-to-one information for me. And you said the ice is better. Potentially, yes, but we shouldn't forget the currently used ice technology is a monoplane system. So if you use a monoplane system, and that's why I raised the issue of complex catheters like Acutus, for instance, or big basket catheters, or ablation catheters with a very complex structure that you have to deploy in the atrium. Those are not easy to appreciate from in a full length using the ice. You can learn it, but don't tell me that you don't lose time with it. And the other thing is, and that's why I was very happy to organize this, because I expected live case. So again, those publications, those beautiful case presentations are very good, but so far all of the live cases, and none of them is from you guys, but all of the ones I saw were not really convincing to me, and then that's. And then I invited already you, Pedram, once the traveling will be possible, or Robert also. I really would like to see one in my lab and smooth in 40 minutes. Beat me 5 times, because efficiency is very important. And then I will be the most important fan of you to implement it in EP. But again, my point was keep it very, very low. Nowadays, low frame rates, low dose, extreme protection makes it possible that you use 30, 40 seconds with a very low dose. It should be enough.
Okay, just to jump in. All right, just to jump in. In terms of, I like the fact that your colleagues or your guys that graduated from your group were getting it down, lower, lower, lower. That's actually the way I developed, going from 2 minutes down to no minutes, because most of us concentrated on the actual transeptal, right? But here in the US, we have ice. So once we figured out that, hey, I always look at the ice and I don't cross unless I'm in the foramen, that actually took fluoroscopy completely away. But in terms of your other point, because we are electrophysiologists, we deal with the most beautiful organ in the body. Every place in your heart has what? A signal, right? So we're not only looking at, in your case, fluoroscopy, in our case, ice, as well as the actual mapping system, we're looking at signal. So if you're in the liver, you shouldn't have signal in your liver, right? And you shouldn't have signal in your SVC or IVC. That tells you where you are. And I look at each and every one of these things. And for people out there who are listening to this, when they're developing their own sans fluoro techniques, this also confirms, hey, this is where I think I am. My signals say I'm here. The device or the mapping system says I'm here, and the ice actually confirms it. But I get it. I get it. And I'm hopeful, Dr. Tamas, that you get there too, because we can be EPs at 100 years old, sitting outside the room, like, Professor Ernst is talking about, getting no radiation, wearing no lead, and hopefully continuing to do this even when we're old and gray and Methuselah-like. But I understand in the early development, there is a learning curve. But I truly believe that everybody can get here.
Yeah, maybe it wasn't clear. I meant actually technologies that doesn't have signal. So I'm talking about therapeutic catheters which are recently developed, and obviously I don't want to deploy an Acutus catheter in a liver to check it whether I'm in the right spot. And some other ablation catheters also not particularly good in showing signals, like a cryoballoon. It's maybe not the best example because it's easy to do a cryoballoon probably with fluoroscopy, but you understand my point. And I'm talking about new innovations as well, which are coming.
And sorry to interrupt again. it took me a while to go from zero fluoro for radio frequency to actually doing it with cryo. And for your very point, but again, the visualization with ice, as Dr. Kazemian was talking about, actually helped, okay? With the actual seeing of, I think they have an Achieve catheter or something like that, and seeing the balloon occluding, and you look for 2D, looking for flow, also looking at pressure measurements, that's how most people are doing it in a zero fluoro way. Because that one, you used to get the most actually fluoroscopy doing it with cryo. And this is why I went away from it before coming back to it with the zero fluoro manner. But I digress. You've done many more of these in terms of RMT and everything else than probably all of us combined. So I'm just hopeful that everybody gets to, you know, where Pedram is, and hopefully where I am can continue to be.
Yeah, I agree. One thing is, there are some questions in a chat, and then they suggest that without ice it's difficult. So they mean probably Europeans, but actually I wrote my PhD from ice, and we are a center that used almost 100% ice. So that's not true for us. But what Sabine mentioned, that in Europe, the use of ice in general is much less than in the States, but not necessarily in our centers.
But this is not something that is ice related. I really strongly disagree. So you can be zero fluoro without using ice.
Yeah.
I don't want to get this symposium or the Europeans feeling, oh my God, we are so far off, we cannot do zero fluoro. What Robert said is very, very true. Look at the signals. That's number one. Never move a catheter without a cable connected. Otherwise, you can't see the signals. I see so many people advancing catheters up to the heart. And I was trained 25 years ago to advance a catheter. Yeah, if there's no resistance, you just advance the catheter. Yeah, you go with a J tip, you curve your catheter. It's atraumatic. You cannot get stuck anywhere. Once you're in the atrium, you see an atrial signal. That's so simple. You know, this is a, how can I say, an ancient trick. What else are we looking at? We're looking at signals. You know? So I feel exactly the same, let's say, passion that Robert faced. And then you have to work around it. And again, I put in the chat 2 references. The way that I do zero fluoro transeptals is not so difficult. You could even exchange the RF needle to a normal needle and fake it differently. You can fake the tip of a needle as a catheter on the 3D mapping system. That's how pediatric people have done this they do zero fluoro for 15 years. They would laugh at this and say, great guys that you catch up with us, you know, because they have done exactly that for children. And I've treated pregnant ladies with zero fluoro 15 years ago. So that's not, you just have to have, and that's where I try to get both of you to comment on what is getting, or what changed your mind. I think Pedram said he had a colleague who had cancer, or maybe that was Tamas, and what's the, you know, I like this competition. We always competed against each other, who has a lower fluoroscopy exposure, and it's was like playing a game, who has a better high score, and say, oh, I did it with a minute less than you, yeah, and that how, you know, we all came down. But making that last step for this kind of uncomfortable, do I really do it? Do I really take my lead off? And once you start doing it, you feel more and more comfortable. You have all the information that you like. But that mindset change, I'm sure you are surrounded by colleagues who still use fluoro. So how do we implement? You can make a decision for yourself, but how is the motivation to move the field towards zero fluoro?
So for me, it was actually not so much radiation, was the orthopedic problem with back pain and things like that. And I wanted to not use it. So early on, I set a goal of doing fibs less than 10 minutes radiation, then made it 5 minutes. Then, and along with that, I did other things as well to minimize the invasiveness of the procedure. So we used to put Foley catheter in everybody, arc line, double transeptal. So I gradually cut those things out as well. And but if you reach a point where you still have to wear the lead, even if you're doing a 1 minute, and that didn't do it for me. I still needed to get rid of that lead. And so I looked around, and initially, as I said, I did not have any pride issues saying that, oh, I absolutely will not come on fluoro. So if I couldn't do it, I'll do a quick fluoro to see what it is. But as you become more and more experienced with the images, then you realize that actually those images are way superior than the fluoro. So then you question yourself, why am I using even the fluoro to confirm what I'm already seeing on my imaging and my electro-atomic mapping? And as you said, for kids and for, AV and RT case was the 67, but most of the AV and RTs are in 20-year-olds or 30-year-olds. And there is absolutely no advantage in using fluoroscopy because it doesn't show you any EP-related anatomic location. It doesn't tell you where the hiss is. Eventually, you have to look at the map and the signal. Well, you have the map and signal in front of you, so why not use it? And then get rid of the fluoroscopy for those ones. And then gradually move to so start with the right-sided, maybe flutter, maybe even RT, ATs, and then go to the left side. And once you do the transeptal, then there is really not much difference between PVI and VT ablation in that sense, because what differentiates is going transeptal. So the transeptal is fairly easy, I would say. After 30 cases of doing fluoroless, you should be competent enough to do it fluoroless confidently.
Agree.
So let's move on a little bit, and there are quite a few things which would be nice to discuss. And one of the things is here, when you look at probably not only EP, but in medicine, success of certain things, standardization is a very important issue. How do you see in the future, how can you standardize this? Because obviously, it seems that there are some zero fluoro centers, or even physicians probably, not the whole center is using that. How can you make it standard? So the major problem when a technology is not getting used in a wide range is usually because it's not it cannot be standardized. So it's highly depending on the individual capabilities. And when you look at, for instance, the success of cryo, I do believe it's one of the reasons why it's so successful is that the results are pretty standard. Procedure times are standard. How do you see that in a zero fluoroscopy? How would you be able to standardize it that every single EP guy will be able to do the same with the same success?
I'll start. I think your questions, that's a very large question. I think it has to start in fellowship. I think that EP has been very kind of dogmatic in that your senior colleague taught the junior colleague who taught the fellows, and they didn't come around when the mapping systems or every new iteration is so much better than the last. And as Kazemian was saying, this gives you a much better picture for us, okay? And I think that this may need to be put into fellowship programs, or even coming from the radiation side to say, hey, we should do our best to minimize or eliminate radiation, and as low as reasonably achievable needs to become even less. I think that's the only real way to kind of standardize, and more studies, okay? More studies. There's still not a large randomized multi-center study looking at a particular type of ablation, whether it's PVI, whether it's VT, whether it's AV and RT. Actually, there's one for SVT, but looking at each individual ablation, because you're in different places in your heart, may be a little bit harder. So I think we actually need to have more zero or sans fluoro studies done that are randomized, but nobody's going to do a sham study. That's the thing. And so my whole philosophy behind this was, why am I putting my patients at risk? Okay. No amount of radiation has been shown to be safe. So is that actually, something good to do, to say, okay, I'm going to put 500 patients and make sure they get at least, 2-3 minutes of fluoroscopy when I know I can do it with none, just to say it is just as good?
Can I interrupt you?
Always.
I understand your philosophy, but if you think like that, you always have to look at the balance. So you have an electrical storm patient. There, the risk or whatever of not treating it is much higher than treating it, even with fluoroscopy. I understand that's your major enemies at the moment, but if I translate it to interventional cardiology, and I follow your logic, then we shouldn't do any CTO openings at the moment, because radiology is our number one enemy. How do you, what would you comment on this?
Well, you know, you always look at the end results, right? If you have to say it's epicardial, if you have to. But when there is an equivalent way of doing it that has been shown in multiple studies, feasibility, safety, and there's no time, maybe during the learning curve, but after, as you know, Pedram is saying, after 30 cases, you're not using any more time. Why are we putting our patients at risk on the back end of untoward events? This is what I'm saying, okay? Yes, they need their VTs treated. They need their PVIs done. They need their AVNRTs done. Everybody is agreeing with that. But even as Professor, you know, Sabine was saying, our pediatric colleagues have been doing this for years. So why should we treat children and pregnant women better than our patients just because they may be older and not pregnant?
So Tamas, I have
so I think coming back to how can we do this? How can we get people changed? I think it's training. I think we need to train people. And again, I think magnetic navigation is so good because you're so close to the signals. You're just sitting there. There's no way of escaping looking at the signal. Yeah, and you're not distracted by looking at various things. You know, you have it pretty much kind of condensed in front of your kind of central view when you do your procedures. And you're probably not distracted by trying to hold a catheter in place. This is for a beginner something difficult, right? To be there and stay there rather than other things. But I think simulation training and awareness, I think, is a key feature here. And I wonder how we can implement that. I do this with my fellows. They all do phantom mapping first. 3D prints are nearly everywhere. You can just stick a catheter in, put a box around it, put some stickers on, and then you're off you go. You can train without X-raying, or maybe if you X-ray in the beginning. I think that's probably the learning curve, and I think you both have pointed that out importantly. Don't go in, no lead on, and think, today I'm not going to X-ray, full stop. No, go start doing your normal procedure and think hard. Why are you turning? Why are you switching the foot switch on? Why are you stepping on the, what was that additional information that you got from looking at the X-ray? Or would you got the same information from your 3D mapping system or looking at the signals? So that's always the question. If you have to, and you feel unsecure or you think it's a tricky thing, I would always fluoro. You can block the fluoro with a fingertip. It's not very far. And you say, okay, I'll have the fluoro blocked. That's how I trick myself. So I had the fluoro blocked. And even if I push my foot on the foot switch, I wouldn't see a picture. I would need to do one more step to turn the X-ray on. To really, let me reflect again, do I really have to do it? Why am I want to do it? Is this the right projection and I want to see it? And then I thought, you know what? I think I see it on the carto, or I can see it on the signal. I think I know where I am. And then that changed the way. And then I didn't activate the system anymore. It was blocked all the way through. And by now, and this is another thing, I think Robert mentioned that peer pressure again is, I think, a great thing. My nurses and my physiologists love the fact that I do zero fluoro cases because they don't have to lay a lead, they just kind of walk in. In fact, nowadays, anesthetists, if I do fluoro, I have to tell them. And I said, guys, don't walk in because actually this is not a zero fluoro case. We say which ones are zero fluoros and which ones are not because people just walk in. They just assume that's my cath lab list and there's zero fluoro. So I think that's, it's a learning curve. It's a personal learning curve. And the question is how to motivate people to embark on that journey to do zero fluoro. I think all the junior doctors are quite keen. They're also more aware. And my experience is that more senior colleagues said, I've done this for the last 30 years. It's not harmful. My brain is still where I am. I still look straight through my eyes. And they might not be as interested. And again, maybe the final statement as a female operator, I think women are just a little bit more, let's say, sensitive to the topic. You know, we have something to lose, and it's important. I think it's really for our professional risk, it's very important to have it as low as possible. Doesn't necessarily be to absolutely zero. Yeah, I think a minute or two wouldn't kill anyone, wouldn't probably risk increasing the personal radiation risk. But still, I think we should take all of the information. So it has been there, as we have discussed. It has been there for decades. It has been there from the very beginning. You know, Catheter was marketed as the zero fluoro system.
Yeah.
It was a non-fluoroscopic system, and it is. It has always been.
Yeah,
and it actually works.
Yeah, thank you. Excellent. And there is one comment I would like to read. The empathy with patient is important. I don't think we disagree with this. Otherwise, we wouldn't be here. And there was one more question from Pete, or more a remark that his perception is that RMT can help. And I think it confirms what Sabine said. To understand, you're closer to the signals, but also you probably understand in an environment when you really have a very atraumatic catheter, the 3D maps and the signals.
Yeah, just to say something on that. Sorry. Just to say something on that.
That was the third issue I wanted to raise, that for SVTs, if I looked at your cases, both of you, you use CARTO when you apply zero fluoroscopy, while in many centers, I suppose, for a simple SVT case, AV nodal, WPW, at least in our center, we try to use a minimal invasive approach, I call it, with a limited amount of catheters and definitely no ice and no CARTO. Any comments on it? Is it a crime to use like a half-minute fluoroscopy in those cases?
So if I may,
it was a joke. The last question. Yeah. More a comment about the need for a 3D mapping system in those cases.
Yeah, I don't think it's a crime. I mean, who used CARTO, 20 years ago for AV and RD? I mean, this was fluoroscopy, so you don't have to. But going a few comments about very important things you raised about the standardization of the fluoroless is that number one is that I think to a great degree it is already a standardized. If you, I'm looking at what Robert does for his AFib and what I do. I mean, we didn't train together, we don't work together, but our procedure is roughly the same. So that tells me that it's already automatically standardized to some degree. The other thing is that the fluoroscopy method is also not a standardized. You show me two people who do Vt ablation identical to each other. No, everybody does different. Some people do induction, substrate mapping, lava, they have other methods. So there is some variation even in the other ones. The third issue is that there is new technology coming in. For example, for this simple thing for measuring esophagus temperature, there is nothing there. So you have to make it yourself. You have to attach a quad to it, tie it, put it inside. So as these new technologies become available, and the Agilis, for example, now I don't use it, but it's available. You can hook it up to your CARTO. Then it creates some variation between different people just because new technology coming up. So I think there is already some standardization. And things that work tend to stay around.
Very good. Yeah.
1 second. For your AV and RTs, the one good thing about having a mapping system that I found is versus when I first started doing them with complete fluoroscopy is you can tag places that you've been. Okay, so if you're having trouble getting junctional rhythms and your catheter can move and your eyes will not remember exactly, okay, I've been down here. And you can move micro movements and you can tag places that you've already ablated while keeping your His cloud on top. The other thing about it is, and a point that I want to make, when you're first starting out with these, you should always, if things look different, remap. It doesn't take that long to make a new His cloud in case your patient moves, because I don't always put them, in fact, I never intubate them. So if I'm not getting any junctional rhythms, I'll scrub everything, make the His cloud, because sometimes it's moved higher. And so you're thinking you're getting closer to it and you're not. And again, focusing in on the signals, as we talked about. But one way that manual differs from actually using RMT is the non-traumatic catheter. It actually makes it a lot safer for you. So I'm on the bus with, Dr. Ernst about it is actually probably easier to learn how to do zero fluoroscopy, sans fluoro techniques with the actual RMT than maybe even manual. I'll turn it back over, sir.
Fantastic. So I don't see, I just screened all of the chats and Q&A, and I don't see any other questions. Sabine, would you like to raise some other?
I just tried to remind you when we started with magnetic navigation. I know that I think this is my first paper using magnetic navigation in AVNRT. And just using the features that Stereotaxis provided at the time, that was solid tip 4 millimeter ablation with only bipolar signal. So that catheter was terrible, but nevertheless, because we had these reference Ario and Elio X-ray pictures, and you could paint on it. You could paint where the CS catheter was. You could paint where the His recording was. You could paint where. So basically, it was, in a way, so far ahead of time and what the image integration, the kind of the tricks on how to remind yourself where you had burned. That was not automatically, you just couldn't hit the space bar and then it was, but you could take a little point on each Ario and Elio pictures. And all of that came together. And actually, a lot of features that we have now in advanced 3D mapping systems are coming from exactly that we have learned and how the signal looks exactly there. And you can basically show me any signal. In Sinus, for me, it's very simple to tell you where the catheter is. I'm sure I'm right within at least 2 square centimeters, probably much, much more correct, just by looking at where we are. So I think, it's a learning curve. We need to put it all together. We need to push probably for even more integration. That's my take. We haven't spoken much about 3D image integration. I do this all the time because I do a lot of congenitals. Knowing how the heart looks for an individual patient ahead of time is a great advantage. I do 5, 6, 7 hour procedures with less than a minute of fluoro in the most complex procedures just because I know how the heart looks. I don't have to, I'm not wondering where I am. I know exactly where I'm going. So all of these things, I think, putting together and the open platform that Stereotaxis provides, I think is really good for us to make these kind of learning steps and get step by step where we should be. And again, I personally agree with both of you. Zero fluoro is the way. There's no point in doing it if you can avoid it. Why exposing yourself? But of course, not on the expense of success of the procedure. And I think that's where Tamas comes in and said, okay, if I expend the procedure duration for 40 minutes or whatever, even 20 minutes maybe, maybe it's better to just go and be quicker at the target site or something. I think we need to push for that and see how much value we give for fluoroscopy in this kind of setting. And I think fluoroscopy is not minor, again, for all the reasons that we discussed for our risk, but also for our patients' risk. But I think we need to keep this good balance. To say as low as possible, achievable or reasonably achievable is quite different from just taking advantage of all the steps that we have, all the technology we can engage. And quite frankly, I think by now, I feel it's nearly a crime not to use a 3D mapping system to see where the catheters are, especially in young patients with SVT. I see no reason not to do it.
So I completely agree. So maybe I look like an opposition here, which is definitely not the case. That's why I have to confirm what I said at the very beginning. If this pioneering work is a way to get rid of X-ray from the EP lab completely, then this is the way to go. But that should be the ultimate aim. that we will have EP labs without X-ray machines, and then we all agree. What I'm saying that currently a few seconds use or whatever doesn't matter. I mean, Pedram was talking about comfort of his back. So let me have also comfort in my mind having 2 or 3 seconds fluoroscopy. It's the same thing. So it should be good. It should be safe. If somebody proves to me that low dose, low frame rate, half minute fluoro is very dangerous, I will stop using it. But until then, I will take it as an let's say that a counterpart of the back of Pedram to make my mind peaceful. But otherwise, I think we all agree the end should be that fluoro out of the EP lab, right?
Yes.
Okay, Sabine, some closing remarks?
I think I've expressed everything I feel for this, and I love the passion of our discussion. And I think, yeah, we need to continue pushing for things like, you know, Pedram showing this kind of mini electrode magnetic mapping that would make more parts of the procedure magnetic, and we remove ourselves to the control room. And lots of little steps where we need to push for more implementation. And maybe targeted identification, you know, go with a single catheter, you know, four wire studies for SVTs, you know, and again, you know, I didn't comment on that, but, you know, if you know the anatomy, if you have understood the mechanism, you know, you probably don't need four catheters at anything anymore. So lots of things where we need to push forward. And I think that's really where the masterclasses are aiming for, to show different practices. And also show tricks. So I have learned today that I've not to be afraid of people who have their indwelling leads for many months. I think Pedram said 2 months. I think my device colleagues would rip my head off if I would dislodge a catheter, any lead of theirs, and they would need to go back in. So I'm probably going to stick with a year or so, but I'm going to be more, maybe a bit braver. So lots of little things. And I really liked, I didn't comment on that earlier, in your puncture technique, the vascular axis, where you show the longitudinal and you show with where the crossover is, with the bifurcation of the arterial vessel. So that's something that I've learned, and I'm going to try to implement that next time I puncture in the groin. I'm going to have a look around and see if I can identify that as elegantly as you did. So I learned personally a lot, and I hope that the audience enjoyed it as well.
And take-home messages, one sentence. Robert, Pedram.
Pluralist works.
Robert?
I would definitely say fluoro should go the way of the dinosaur.
Thank you very much for everybody, and hope you enjoyed this great event.
Thank you for joining the Masterclass 4 Zero Fluoro Robotic Ablation. We are grateful for our faculty, Dr. Percell, Dr. Kazemian, and their teams, Professor Sabine Ernst and Dr. Tamas Szili-Torok, for their enthusiasm in bringing to us the interesting possibilities in zero fluoro robotic ablation. Many thanks as well to Stereotaxis for sponsoring this event. I encourage you to check out the websites of both Stereotaxis and SCRN to learn more or to become a member. On Wednesday, July 28th, SCRN is proud to present robotic and automation in catheter ablation during the in-person portion of the HRS 2021 in Boston. This is a session on the HRM program chaired by Dr. Eugene Crystal and Dr. Jim Chung, and the faculty consisting of the SCRN board members Dr. Daniel Cooper, Dr. Tamas Szili-Torok, Dr. David Burkhart, and Dr. Pete Weiss. We're looking forward to welcome you there. Dr. Percell already announced his debate on the 29th of July. He's having his talk on the 29th of July in room 210A. Should you wish to contact us, please feel free to reach out to us via info@stereotaxis.com or your local representative. Stereotaxis would be delighted to host you for a test drive of the technology. And please note that if you want to review back any of the masterclasses, either this one or previous ones, you can go to roboticep.com telerobotics live or watch it at SCRN YouTube channel. For now, I wish you a pleasant continuation of your day. Good afternoon. Until soon at one of our other masterclasses. Thank you.